we start the video session on sonoanatomy. So we have heard about the erector spinae muscles in the back. So let me show you sonoanatomically what it looks like. Now, if you look at this, I hope you people are seeing this demo. This is depth kami karo, Lata. I mean, yeah. No, you're increasing it. Ha, that's it. You can see on the screen that I'm showing you the spine. This is the spinous process, and in between interspinous area, next spine, interspinous area, next spine, like this. And then at the side of this, you first demonstrate this and then go to one side. This particular, increase the depth now. Now increase the depth some more. Yes. See, in this, the black area, I am unable to show it on that machine. You cannot, they'll show only that. So I am trying, how to, एक minute. नहीं, stick देऊन काही उपयोग नाही. ते directly जातात ना. I can't mark. No, one of you will have to do this. Come here. Bring this cursor. You have to come on this side. Come on this side. See, take the cursor and show which is the spinalis, which is the, yeah. See, in this place, you are seeing the, here you are seeing the lamina. Please show the lamina, not this, the below that. That shiny thing is the lamina. The white muscle on top of that, this, just outline it. Just outline it, cursor, take the cursor around it. This is your multifidus, and the black muscle on top, go there. Yeah, this is your spinalis. The one which is closest to spine is the spinalis. And then next to that, next to this, here is your spinalis over it, and then here comes the longissimus. This much, the one in the center of the screen now is the longissimus, and then here is your iliocostalis. The patient, or rather the volunteer here, is a skinny fellow, but at the same time he is a muscular man, and as a result you are seeing such big muscles. And in this you can see that I have come till here. I am pressing it in the ultrasound. You can see that I am pressing the iliocostalis. This is the iliocostalis, and till here in this fellow, right from here, the muscle is coming like this and going up. Okay, so practically the more than 2/3 of the back is covered by the erector spinae, which is iliocostalis here, longissimus here, and the spinalis. And here comes the center, spinalis, longissimus, iliocostalis. Is this clear to the online people? How do we ask them?
Yes, Lakshmi, we can hear it, we can see it.
Yeah, you can. Good. So now below that, thoda depth increase karo. Now if you see below the, please point to that. Show the iliocostalis. Yeah, that's the iliocostalis. Below that you can see a clear, yeah, just come below. This is your quadratus lumborum. Can you see the quadratus lumborum? Please outline it. Yeah, this whole thing is the quadratus lumborum. Can you see how thick the muscle is? The whole muscle is clear. All right, and beneath that is your peritoneum moving, and the retroperitoneal area that is going on. So in such a patient, let us say you want to do ultrasound guided dry needling, but you don't have an ultrasound machine at your clinic. So what you would have to do is to get an expert ultrasonologist, do the ultrasound and see how deep is the quadratus lumborum. So in this patient, I can put a needle. Am I showing here? When I'm going here, I can go till this. How many centimeters is that? Please show. It is about 4 centimeters. That is 4 centimeters. It is still 3 centimeters. So if you can take a 40 needle and leave about 1 centimeter, and also please understand, I am pressing the thing here. If I take away the pressure, it becomes almost 4 centimeters. So 4 centimeters is the needle to be used in this area. And here, if you were to see, in the center, right next to the spinous process, if you wish to enter, this is it is about 3 centimeters again. Show the lamina. That is the facet. What she is showing there, show the outline of this. That is the lamina. Go up. That is your facet. You can even see the 2 lips of the facet there. Yeah. Are you able to see? Yeah, that is the facet entry actually. Come down to the lamina and show. Yeah, that is the lamina. So from the skin to the lamina is about 3.5 centimeters. So 40 needle would be enough to do all his proper needling to the depths of the muscle. You can easily do with a 40 needle for the spinalis, for the longissimus, and also for the iliocostalis. Okay? Is that clear? Anybody has any questions?
And can you show the QL again, the black?
Okay, I'll show you the QL. I'll show you the QL.
QL.
I'll show you the QL again. See, can you see this?
The dark one.
Dark one below.
Huh.
That is your QL.
Right.
Yeah. Okay. I'll go medially. Can you see?
Okay, yeah.
Now can you see it's extending medially here? It is going deep. If you see below the facet, please outline the spinalis. Go there. Come from there, top. Come down. No. Come all round. Come all round. There. Come down. Down. Some more. Till here is the spinalis, which is sort of making a nice, good round cap around the facet also. You can see the facet there. And if I go here, you can see the lamina. Are you able to see the lamina there?
Okay.
Lamina, the facet, and then the spinalis overhanging like this, and the QL is here. Can you see the QL there?
Yeah.
Below. See, that is the lower margin of longissimus. Go up a little. That is the lower margin, the deeper margin of longissimus. And this is your
And how do you see the
quadratus
transverse
lumbar.
process here? Is there any tip of transverse?
The transverse process in this view is difficult. I'll show you the transverse process.
No, I mean, I'm remembering that clover sign somewhere.
The clover sign and all that is very difficult to show with this machine. With this machine. Probably even with a higher resolution machine, it's difficult to show. But quadratus lumborum is seen very well here.
Okay.
Right? Are you able to see?
Yeah.
Now, I will show you sometimes, okay, you want to see transverse process, right? That's what you wanted to see. Let's see if we can show you the transverse process.
No, you showed in the picture psoas and.
I'll show you the psoas. I'll show you this. Wait. I'm still in the posterior aspect. Okay.
Okay.
See, here you can see.
Spine.
No, you can see the
That is
transverse.
process.
That is that is the this one. That is the facet. Come here below. Can you see the bone there?
Yeah.
That is the transverse process.
Okay.
Okay. Bring the spine model. I'll show. Freeze this. Yeah.
Okay.
Now I will show you on the spine what it is looking like. Just run through this, Janvi. Take this. Yeah. Spine. Go, no, you. take the, okay, that is the spine. Just follow it down to the lamina. Yeah, outline the lamina there, facet. Yeah, and come down. That is the transverse process. Okay. This is about the view you will get like this. If you take a bigger convex probe, you will see this even better because that's got a wider area. So, can I show you? This is focused. So, what you are seeing is a view, spine, lamina, below that the transverse process. Spine, lamina, facet, transverse process. Is this clear to you people? Yeah. Should I bring it closer? Keep it there only. Spine, follow it down, lamina, facet, and beneath that the transverse process. This stepwise. First step, second step, little elevation there, and then the third hyperechoic tissue. So a structure. Just show it there. Go there. Go take your cursor. Stop there, spine. Come down to lamina, first step. First step. It goes up a little. That is the facet. And then third, come down. This is your transverse process. Okay. So now I should come. I'll show you the quadratus lumborum in the vertical view. See, now this, you should see this kind of a structure. Can you point out now? See, you see the spine just under the skin. Can you see the spine? On top, show that. One spine. Show the upper spine this way. That is the upper spine. Go down. Intervertebral space. If you wanted to put an epidural, you will have to go there. And this is the second spine. Okay. This is in the center. You can see I am in the middle. And then from there, if I want to come, as I come here, you can see the laminae like horse. It's going like this. Yeah. The muscles on top of it are that would be the spinalis. Right next to the lamina will be the multifidus. If I come a little further down, you can see it very well. See the fascicular pattern. Go there. Top. Yeah. See the line fascicular pattern in the muscle. When you see patients with failed back surgery syndrome, you will see this fascicular pattern is lost, and it's just a mass of amorphous tissue that you see in those patients. In fact, you can see the opening of the facet. See this, Janvi? Show the facet there. It's seen so well there. No, not that. Thoda upar jao. That is your facet. Okay? But it will go away here. I have just moved a little medially. See, I am here. You can see the facet. With this camera, you can see this is the facet. But if I just move the probe a little medially, the facet is gone. Okay? And if I come here and come out a little more laterally, the facet is gone. And now probably here will be the transverse process. One transverse process to the next transverse process. And the same thing, if you go a little further away, you can see the trident sign, which has been described by Manoj Karmakar. See I think we'll keep it like this, so that, yeah. So you have the spine, laminae, and as you come here, you will see the deepest bone, that is the transverse process. And the same thing, if I come here, it becomes the trident sign. Can you see the two spine transverse processes? And the muscle there is the psoas. This is the psoas. Tomorrow we will be doing needling for the same person because he's got backache. In fact, he was indicating to me where his pain was, but I told him I'll do this tomorrow, wait. This is seen even well now, the transverse processes, like a trident. There is, all of you who are AORA members will know Dr. Manoj Karmakar. He has described this trident sign because he is a pioneer in ultrasound, and he is also described the spine ultrasonology. And his workshops are very, very good actually. So now I have shown you the erector spinae, I have shown you the psoas, I have shown you the multifidus, I have shown you the quadratus lumborum. I also have to show you quadratus lumborum longitudinal view. This is your longitudinal view. See, freeze this. Yeah, get the cursor. Cursor. My showing I cannot, they'll not see. Take the cursor. That top is your probably the longissimus. Okay, because I am at my probe is here. So this is probably the longissimus. And can you see the lower clear quadratus lumborum? Yeah, that is the quadratus lumborum. Just outline it. Yeah. Yes. Beneath that will be the peritoneum. I think take off the unfreeze. Depth increase karo. Can you see the peritoneum moving below that?
Yes.
The quadratus is seen very well. So doing this needling should not be a difficult thing. The same quadratus, please look at the probe. When I am here like this, quadratus is seen. But when I angle it like this, I will be seeing the transverse processes. So now freeze. So in this frame, we are seeing, go on top. This is your probably the iliocostalis because I am more lateral. Then the next muscle is quadratus that we are seeing. This that is quadratus at the level of the tip of the transverse process, and then the one in between the transverse processes here. Yeah, this is the psoas. So with ultrasound, you can see very well which are the muscles, and you can put needles in these very clearly, unequivocally. There is no confusion about this. And this is a thin, lean man, muscular man. So it's a very easy demo. When you have an obese woman, the muscles are hardly seen. There is more fat than the muscle. And the muscle's quality also is poor, in that there is more fibrosis in it because of degenerative changes of age, not because of trauma fibrosis. The appearance is very different. It may not be so clear as this, but something similar you will be able to understand after you have done, say something like if you have done ultrasonography in 15-20 patients, then you know what the ultrasonology looks like. The answer to learning ultrasound guided dry needling is to see the normal anatomy in a normal person. Make yourself familiar with what you are seeing, and then only you can attempt needling. See, I bought the ultrasound machine about 10 years ago, 10 years ago, 8 years ago, whatever it was. After we bought this, probably every afternoon we would make this fellow, or we have two people, one skinny fellow and one obese girl. So the easy part is with the learning is with the thin fellow, and then take the obese lady and see the anatomy in her. So you have to identify in both so that you have an easy situation and a difficult situation, so that when you see a difficult patient, it becomes that much easier to do so. So now I have shown you these muscles. Anything else you people want me to show you? All the back muscles I have shown you.
Let's see if there are questions.
Yeah, please ask the online people if they have any questions. Then I'll go to buttock, legs and other things.
Finis dorsi, when you showed, how do you see it?
Save this this one. Save label it also. Okay, label it, and then you can ask the question. You label this so that, and save it so that they can have this.
No, no, I asked.
No, you please ask on this so that everybody hears the
Yeah,
question.
no, no. Do you see now
TP.
latissimus
TP.
dorsi when you do you have to
Latissimus
scan?
dorsi at this level is very thin. I'll show you. I'll show you. It is possible to. PS please. PS. And upper, that is erector spinae, probably iliocostalis. I see. Okay. Okay. Now question.
Ma'am, can you show us latissimus dorsi in this lower
Yeah, I'll
back?
see. I'll see. So you can take this. I think I will make this kind of an image and show you at other places also, so that it is easy for you.
Yeah.
Now here, 1 minute. Freeze this. Depth come kar do, so that it's even more better. Okay, freeze. So this is longissimus on top. Label it, label it. This is meant for demonstration, no?
Oh, that huge strip.
Huge
Oh,
thing
okay.
is longissimus.
was,
This is the quadratus
longitudinal
lumborum.
Okay.
So what you have to do is you have to take the probe position also. So can you take a picture like this? No, you just take a still picture.
Still picture.
Yeah. So that if we can put it on that, it will be very nice as a picture in picture.
Yeah, take it from
Oh, take it from the phone. So this is the image which showed the psoas. Okay. This is the way to hold a probe when you want to see the quadratus lumborum.
Okay.
Okay. To see psoas, you have to go this way,
Oblique.
oblique. And here you can see, to see the fascicular structure of the muscle, you have to hold the probe like this vertically. And if you want to see the same thing in a different view, you have to hold like this. In this muscle, I want you to see that there is a lot of black, but there is some white also. This is the connective tissue framework. So a muscle actually is like the honeycomb. The honey inside the comb is the muscle. The honeycomb itself is the connective tissue skeleton of a muscle. Okay? These structures are very easily seen. I am showing you with a very simple machine, whereas if you see it with a high-end machine, it will be even better. Okay?
And Dr. Sushma has said, please show multifidus.
Okay, certainly. Yeah. Depth come karo. See, multifidus sometimes may not be very easy to see. See here. Can you see this? Yeah, here. Okay. This side was easily seen. Okay, freeze. Or hold on, unfreeze. Unfreeze? Yeah. Freeze. Yeah. Now look at multifidus MF, MF, and spinalis SP. Take this one, caliper, manual caliper, manual caliper, manual, make it manual. There.
ऊपर मैनुअल के नीचे.
Outline the multifidus. Come down. Outline it. Can you see the multifidus in this? Come out also some more. Sorry. Delete this. Or go backspace it. It will go. Backspace. Backspace. Right corner, please. No. Yeah. Backspace it some more. Some more. Now go continuously. The white muscle, you can see it so well. Yeah, go out. Till there is your multifidus. Please remember, multifidus is coming from the transverse process upwards. It's a oblique muscle. So that is what you are seeing there. Okay, it is enveloping the facet. This is the reason why when facet arthropathy is there, facet irritation is there, this multifidus muscle, you have to go out a little more also, but it's okay. So basically, if there is facet arthropathy, multifidus muscle is the one in spasm, because the synovium of the facet will have connections, reciprocal connections with the multifidus. It will also have reciprocal connections with the spinalis. If there is facetal irritation, these two muscles are going to go into spasm. And unless you relieve this, you can go do a PRF, rather RF ablation of the median branch to the facet. The facet stops sending irritable messages to these two muscles. But the MTRPs which have formed when the facet was irritated are still there. As a result, even though you treat the facetal problem, the muscle spasm still remains. It has to be remedied. Once you remedy it, things improve. Not only that, if you are relaxing the muscle, relaxing the muscle by resolving the MTRPs, the pressure on the facet itself comes down. So it is not just a treatment for pain and not just a treatment to relieve the MTRPs, it is also a treatment which will de-stress the facet itself. So you are looking at something towards a curative treatment and not a symptomatic treatment. Okay? Anything else? Somebody else wanted something else? Are you happy, Sushma? Is this what you wanted? Anything more you want?
Another question.
Yeah.
Why quadratus lumborum muscle is very hypoechoic compared to surrounding muscles? This is by Dr. Kalpana Ravikumar.
Okay. See, hypoechoic muscle is always a good muscle. He has a good, this one, quadratus lumborum. And quadratus lumborum is also a powerful muscle. So probably that's the reason why it is hypoechoic. There will be, see, more activity. Higher the normal activity, higher the exercise, more hypoechoic the muscle will be. If I have seen some athletes' muscles, when I say athlete, professional athletes, their muscles are a pleasure to see because they are all black and the white is brilliant white. The black is pitch black. Interestingly, I had the occasion to see an African patient. I've treated many African patients for CRPS. They come from Nigeria for the CRPS treatment. And so these people's muscles are wonderful. It is this muscle, I would call it white muscle compared to the African muscle. So there are ethnic and genetic reasons also for the appearances of the muscle. Somebody has to do a study. Okay, I'm just giving my what shall I say, observations.
And Dr. Vasudha is asking, intertransversalis muscle can't be seen, right?
Very difficult to see probably. Let's see if we can visualize it. With this machine may be difficult. Maybe with a high-end machine we can. Let's just see. First we have to see the transverse processes and then look for intertransverses. See, this is our lamina still. Please look at my probe position. It's just paraspinal. And then as I come here is your transverse processes probably. This might be it. Freeze. Yeah. Maybe. See. No. That is the intertransverses. See that there is a clear line there.
This line?
No. I will come and show you that. Sorry. It's a thin muscle actually. So, see, there is a telltale line here, if you see. And then going there. I am clumsy because of my glove. So this is also intertransversus. See the character of this. It's coming like this. Lines are, so I can't show like this. It is like this. Whereas see the orientation here. It's in a different orientation. If you really wish to do intertransversus needling, it is safer to do it with fluoroscopy because you know where you are. Unfreeze. See, it is seen quite well there. Let me also show it with the here is your trident sign. Yeah, 2. Yeah, freeze. Definitely there. That. Yeah, that strip, the top strip. Yeah, that one. Okay. Is that convincing to you or no? It is running between the transverse processes, and more anteriorly or below that is psoas. Yeah, that would be the psoas. Yeah, this would be the psoas. And if you go to the nerve root foramen, your nerve root will be in this plane, somewhere here. Okay, and it can get trapped between the transverses and the psoas. Or if you take this whole thing as intertransverses, okay, till from here to here you show. That whole thing. No, this is psoas probably. So in between the two, the nerve can get trapped. Unfreeze. I'll try to show you again, once again. Yeah. You can see the two transverse processes. Freeze. Freeze. Okay. There you go. Or unfreeze. Increase the depth. Increase the depth. Yeah. Yeah. Trident sign and depth come karo. Yeah. Freeze. So these will be below the transverse processes will be the that will be the transverse process. In between would be the intertransverse. Come down below. That would be the psoas. That line would be psoas. I think now that I have shown you this, I'll just give you a dynamic demo of this. Unfreeze. Coming from the spine, laminae, okay, and then come out. Probably the transverse process is at a lower level, and when I come out some more, I can show the trident sign. Yeah, here your transverse processes. Okay, depth increase karo abhi. Transverse process, freeze this. Okay, TP. Intertransverse IT. Yeah, that would be IT. Niche. Or niche. That will be psoas. See where the white line is. That white line. Go up there. Go up. Come down here some more. Little more. Little up. Towards the white line. Not there. Here. Yeah, next to that. That would be somewhere near the nerve root foramen. Okay. Give me the other probe. I'll show you the epidural space also, you can see. I think we need to move to the other areas now.
Ma'am, anything we should be careful about, like kidney or something?
Kidney will be above. I will show you. Okay, save this and unfreeze. Save this. Save. Press save. Unfreeze. Yeah, unfreeze. Okay. Kidney, if you want to see, here will be the kidney. You see it like a gola. Can you see that moving thing? That black thing?
Okay.
That is the kidney.
Acha, so black. It will
Yeah.
be hypo.
Please see this, where my probe is.
Yeah.
And it's a completely black thing. It's like a vessel. It's a tissue. Okay, it's not like the hypoechoic appearance of a muscle. The hypoechoic muscle has what is called as a contrast. It's got muscle which is hypoechoic and hyperechoic connective tissues. Okay, yeah, give me the other probe. Yeah, give me the probe.
Ma'am, from Rajesh Mahajan sir, we have a question.
Okay, give it to me. I think I'll go to the other areas so that the offline people can do hands-on for themselves.
We have one more question, ma'am.
Yes, please.
So the intertransversus will always be needled if psoas is needled. What if nerve is hit between these two muscles?
Yes, sometimes you do hit the nerve. So when you are going near it, go slow, that's all.
Same question.
We have a question from Rajesh Mahajan sir. So intertransversus muscles will always be needled if psoas is needled. What if nerve is hit between these two muscles?
Yes, sometimes you can hit the nerve. I have hit the nerve, but you should do it in such a way that you go very slow, so that the patient will tell you. Shock sarka yete. Sarka manje, it's like a shock. Sorry, it's like a shock, he will say. Whereas if you go and hit the nerve, he'll say he'll jump. So if you go slowly, you will just go touch the nerve, which they can tell you, patient can tell you. And it does happen. So when you are at those depths, you have to go slow. And you can see with ultrasound anyway. Okay, probe is ready? Curvilinear is what I want. Okay. Okay. See,
Ma'am, it's been removed.
oh, it's been removed. Okay. See, this one, ultrasound guided dry needling is safe, provided you know where you are going and how you should go. Just because you are seeing, it doesn't prevent you from going and sticking a needle right into the nerve also. It can happen. So just be cautious, that's all. Like in the leg, when we are doing the hamstring muscles, you have to always go slow when you are here. Near the, when you are passing the bicipital muscle, you have to go slow. Then only you will avoid any shock sensations to the patient. And does touching a nerve cause any damage to the nerve? No. So far, no. Okay. And there are enough studies from regional anesthesia which have shown that you can go through a nerve, nothing much happens to the nerve. The damages all come when you inject something, and particularly if you inject something acidic, like a local. See this trident sign, beautifully seen trident sign. Depth come karo. So this probe is a lot better for showing the trident sign. Depth come karo na or karo, or. Yeah, there you go. Can you see the quality, which is different? Yeah, intertransverse will be there. If you go deeper, go down. When you are in this area, obviously you have to be very cautious. And you can see the needle. Tomorrow, let's see if I can show you this. Okay? All right, this is it. And if you look here with the probe vertical, you can see the quadratus lumborum so well. Can you see? Yes, there. That is the quadratus lumborum. Yeah, somebody said this is darker than the erector spinae. Whatever is moving below that is the peritoneum and the retroperitoneal structures. Okay, and somebody was asking about the kidney. Yeah, there you go. Okay. No, this is the kidney. You can see the structure. You can even take a kidney biopsy there if you wish. That's what they do. They demonstrate it like this and take the kidney. See, the gola is seen so well. See, can you see? As I go down, it is gone. Can you see the lower pole of the kidney there? Yeah. So now, where do I go? I go to the buttock and lower limb.